So once we've made the diagnosis that this is sigmoid volvulus, the first thing we're going to do is actually a proctosigmoidoscopic exam, and this may even be preferably done with the old rigid instrument rather than the newer, smaller caliber fiber optic, because going through the inside we can untwist that loop of valve and then leave a long rectal tube to prevent twisting again. At a future date, the patient may need sigmoid resection if these episodes keep recurring. But the initial management of the initial episode can be done with the proctosigmoidoscopic exam and a long rectal tube. Well, here we have now another vignette of an old patient with abdominal pain. Vignette number 43, a 79-year-old man with atrial fibrillation develops an acute abdomen. He has a silent abdomen with diffuse tenderness and mild rebound. There is a trace of blood in the rectal exam. He has acidosis and looks quite sick. X-rays show distended small bowel and distended colon up to the middle of the transverse colon. Remember, we said a few minutes ago, when we see a question of acute abdominal pain in a very old patient, we should be thinking of either the sigmoid volvulus or the mesenteric ischemia. This one is a mesenteric ischemia. And the first clue was in that first line that the patient has atrial fibrillation. Because the way you get to the acute embolization that occludes the superior mesenteric artery is either from the atrial appendage in a patient that has atrial fibrillation, or from the mural thrombus in a patient who had a myocardial infarction a few days ago. So the vignette will begin with this old person who either has atrial fibrillation or had a myocardial infarction just a few days ago, and then goes on to develop an acute abdomen. And this is a pretty peculiar acute abdomen. It's an acute abdomen that also has a little bit of blood in the stool, and there are not too many conditions that mix the two. And in fact, whenever we see a combination of acute abdominal pain and there is a trace of blood in the stool, we should think of an ischemic phenomenon as the most likely explanation. And then the rest of the picture is pretty good for it too, because you have the distension up to the middle of the transverse colon. That's the territory of the superior mesenteric vessels. And then you have the very sick patient already with acidosis because there is dead bowel inside the abdomen. Now, given this vignette with this many findings already, the only thing that can be done in this patient is an exploratory laparotomy. We will find dead bowel most likely. We will have to resect that. If it is the entire small bowel, there may be in fact nothing that we can do for the patient. If it's a smaller segment, we would hope we can resect it and save the rest. And because this is so devastating when it gets to this point, there is a move afoot, a move that has been, the work of young, recently well-trained vascular surgeons that are saying to the rest of the medical community, look fellows, don't wait for the old man with atrial fibrillation to develop the full-blown picture of an acute abdomen, because by then the bowel is dead and it's too late to do anything. But if you would call the vascular surgeon immediately, as soon as an old patient with atrial fibrillation complains of abdominal pain, and the vascular surgeon may be able to do an arteriogram, show that the origin of the superior mesenteric is blocked by a clot, then go in and operate and take the clot out. So if you're given this vignette as I read it, already 2 days old, already, obvious acute abdomen, blood in the stool and so on, it's exploratory laparotomy. But if you have a vignette that says a 79-year-old man with atrial fibrillation complains of severe acute abdominal pain that began 30 minutes ago, then the thing you want is the immediate arteriogram and the vascular consultation, because they may be able to unplug the vessel. All right, we're going to move on now to a few vignettes that deal with the liver. Only a few, because I'm focusing only on the surgical conditions. Vignette number 44, a 53-year-old man with cirrhosis of the liver develops malaise, vague right upper quadrant abdominal distension or discomfort, and a 20-pound weight loss. Physical exam shows a palpable mass that seems to arise from the left lobe of the liver. Alpha-fetoprotein is significantly elevated. So here we have a gentleman, right upper quadrant abdominal discomfort, weight loss, an individual who had cirrhosis of the liver to begin with. Now he has a palpable mass. We should be thinking, of course, of a cancer developing in the liver, of hepatocellular carcinoma. Hepatocellular carcinoma is quite rare in the U.S., and we see it only in patients that have cirrhosis already. And this is a gentleman that has cirrhosis, is now has a weight loss, has a palpable mass. And the clincher here is the blood marker, because alpha-fetoprotein is the blood marker for the primary hepatoma, the hepatocellular carcinoma. The next vignette gives you a situation that is far more common in the U.S. In the U.S., metastatic cancer to the liver outnumbers primary cancer of the liver by about 20 to 1. So this next one is a more common clinical thing. A 53-year-old man develops vague right upper quadrant abdominal discomfort and a 20-pound weight loss. Physical exam shows a palpable liver with nodularity. 2 years ago, he had a right hemicolectomy for cancer of the ascending colon. His carcinoembryogenic agent, CA, had been within normal limits right after his hemicolectomy, but is now 10 times more. And indeed, the blood marker for the metastatic cancer from the colon to the liver is a carcinoembryogenic agent. So in both of these, we have the suggestion of tumor in the liver, and the blood marker is the one that tells us whether one is primary or one is metastatic. For both of these, the next move would be a CT scan to see how extensive the tumor is. And we would attempt removal, surgical resection, either for the primary, if it can be done, or even for the metastatic, if it comes from a relatively slow-growing primary tumor, which would be the case for the colon. We may help the patient by having surgical removal of metastases, not leading to cure, but certainly prolongation of life. I might add that we can deal with liver cancer in a number of other very imaginative ways. If surgery is not feasible because both lobes are involved or disease is extensive, we can do other things. We can try to do radioablation or ablation of the tumor masses by heat, that is directed the liver with a probe, things of that type. Vignette number 46. Not a common problem, but kind of an interesting diagnostic challenge here. A 24-year-old woman develops moderate, generalized abdominal pain of sudden onset, and shortly thereafter faints. At the time of evaluation in the ER, she is pale, tachycardic, and hypotensive. The abdomen is mildly distended and tender, and she has a hemoglobin of 7. And there is no history of trauma. Before I read any further, if we have a young lady of reproductive age who suddenly is bleeding into the abdomen for no good reason, the first thing we think about is she must have an ectopic pregnancy, because that would be certainly a common reason for intra-abdominal bleeding in a young woman. Well, following that line of thinking, here comes the next bit of information. On inquiring as to whether she might be pregnant, she denies the possibility because she has been on birth control pills since she was 14 and has never mistaken them. And this gives you the clue. One of the side effects of birth control pills with long time administration, like in this case already for 10 years, is the development of hepatic adenomas, not cancers, adenomas, benign little tumors, but they have a nasty tendency to break and bleed. So nowadays, when we see intra-abdominal bleeding for no good reason, not related to trauma, in a young woman who is on birth control pills, the thought that comes to mind is an hepatic adenoma that has broken and is bleeding. You would do a CT scan of the abdomen that would confirm the presence of blood in the abdomen and would show you the adenoma, and then surgical resection is needed for it. Incidentally, this is not a common complication. So this would not be a good reason for women to stop taking birth control pills. In fact, the complications of normal pregnancy and normal delivery outweigh the potential complications of a person getting the adenoma that we're describing here. Let me give you a variation of this theme. It's not written here as a vignette, but I cannot resist using this other vignette here. If you had a vignette that said a 7-month pregnant lady suddenly bleeds into the abdomen, goes into shock. A good thing to think about would be one of those small visceral aneurysms. People can have a small aneurysm of the hepatic artery or the splenic artery, a visceral aneurysm. Small in terms of overall size, but very big in relation to the size of the vessel. They can rupture and bleed massively, and for some reason, that particular complication happens more often during pregnancy and late in the pregnancy. So that, a 7-month pregnant that suddenly bleeds massively, that's not likely to be, of course, ectopic pregnancy. She wouldn't have gone to 7 months and not been detected as an ectopic pregnancy. Okay, let me move on to the next. The number 47. A 44-year-old woman is recovering from an episode of acute ascending cholangitis secondary to cholecystectomy. She develops fever and leukocytosis and some tenderness in the right upper quadrant. The sonogram reveals a liver abscess. You say, we have the diagnosis. What's the big point to this vignette? The point of this exam question is that there are 2 kinds of liver abscess. The so-called pyogenic liver abscess, which is one AIDS, which is invariably nowadays a complication of biliary tract disease, and which needs to be drained like any other abscess anywhere in the body. So this lady has an hepatic abscess. It came because of a cholangitis, and it needs drainage, and this will be done percutaneously by the radiologist. But if we were given a different kind of hepatic abscess, let me read the next vignette. A 29-year-old migrant worker from Mexico develops fever and leukocytosis as well as tenderness over the liver when the area is percussed. He has mild jaundice and an elevated alkaline phosphatase. Sonogram of the right upper abdominal area shows a normal biliary tree and an abscess in the liver. This second one is the other kind of liver abscess, an amoebic abscess. The amoebic abscess is very common in Mexico, and given the U.S. geographical proximity to Mexico, we see amoebic abscesses in this country. We almost invariably see them in a patient that has some connection with Mexico. It's either an immigrant from Mexico, it's an American who retired in Mexico and has been living there for a number of years. So this vignette that is meant to be an amoebic abscess has what I call the Mexico connection. This one would typically be a male. It's about 4-to-1, the amoebic abscess for males versus females. So if the vignette, going back to the previous, if the vignette is a lady with biliary tract disease who now has a liver abscess, this is a pyogenic abscess that has to be drained. But if the vignette is a male, and the male has this Mexico connection and now has an abscess in the liver, that's probably amoebic. And the important point here is that the amoebic abscess doesn't necessarily have to be drained. In fact, most of them don't have to be drained. We can treat them with metronidazole. We have to drain only the ones that don't respond to metronidazole treatment. Now, how do we make sure that this is indeed amoebic abscess? Well, the diagnosis, in fact, is eventually established by serology. But that serology takes time to show us that the patient has the antibodies to the amoeba. And so we begin empiric treatment. At the same time, we drew the blood and are waiting for the serology studies. Empiric treatment with metronidazole. If the patient responds to metronidazole, we continue to treat with metronidazole, and eventually the diagnosis will come back from the lab, confirming that indeed it was an amoebic abscess. If, on the other hand, the patient doesn't respond to metronidazole, the abscess is getting bigger or the patient is not getting better, then we drain it. We drain it percutaneously because it may be that it began as an amoebic abscess and then got super infected, in which case the metronidazole isn't going to take care of the problem. Let me alert you to the one answer not to pick on this question. I'm sure you'll be offered that. And one of the answers that you'll be offered will be, let's put a needle into the abscess, draw some of the pus, and send it to the lab to grow the amoeba so we can make the diagnosis. The amoeba will never grow. The amoeba doesn't grow from the pus. It would grow from the wall of the abscess, but not from the pus. And that, incidentally, is why we can treat it with metronidazole effectively. If the amoeba was in fact growing into the pus, it would be out of reach of an antibiotic. Because it grows in the wall, we can get it with a metronidazole. Okay, we're now going to move to another different topic. The topic now is jaundice. Before we go into the vignettes, let's have a little background information first. Jaundice can be due to three general groups of conditions. Jaundice can be hemolytic in nature, in which case it's typically not very high. The hemolytic jaundice we see in the adult is not 20 or 30 milligrams of bilirubin, it's more like 6 or 8 or 10. But that small amount of elevated bilirubin in the case of a hemolytic jaundice is almost entirely made up of unconjugated, indirect bilirubin, the one that hasn't yet been processed by the liver. Because the direct bilirubin, the conjugated bilirubin, the one that has been processed by the liver, goes on the normal way, in the absence of either hepatic disease or biliary obstruction, goes on its normal way and doesn't go back into the blood. So the hemolytic jaundice can be recognized that way. The next general group would be hepatocellular jaundice. Hepatitis being the classical example. In hepatocellular jaundice, both kinds of bilirubin are up, both direct and indirect, so the diagnosis doesn't depend on that. But on the other hand, in the hepatocellular jaundice, we have typically very high levels of transaminases, SGOT, SGPT, and only a modest elevation, if any, of the alkaline phosphatases. And the third kind of jaundice, which is the obstructive jaundice, classically has both elevations of the indirect and direct bilirubin. In early cases, in fact, a preponderance of the conjugated direct bilirubin. But the laboratory finding that truly identifies the obstructive jaundice is a very high level of alkaline phosphatase at a time when the transaminases on the same patient are not way out of range. They are typically abnormal, but not in the thousands. All right, let's begin to look at the vignettes. Vignette number 49. A 42-year-old woman is jaundiced. She has a total bilirubin of 6, and the laboratory reports that the unconjugated indirect bilirubin is 6, and the direct conjugated bilirubin is 0. She has no bile in the urine. This is hemolytic jaundice. And so the workup on this case is directed at finding out what is destroying the red cells, and I shall not go into that. That's not a surgical problem. Vignette number 50, a 19-year-old college student returns from a trip to Cancun, and 2 weeks later develops malaise, weakness, and anorexia. A week later he notices jaundice. When he presents for evaluation, his total bilirubin is 12, with 7 indirect and 5 direct. His alkaline phosphatase is mildly elevated, while the SGOT, the SGPT, the transaminases are very high. this is hepatocellular jaundice. And the direction of the workup here is on figuring out which kind of hepatitis he has, so he's going to get serologies and so on. But now let's move on to the ones that are surgical in nature. Vignette number 51. A patient with progressive jaundice that has been present for 4 weeks is found to have a total bilirubin of 22 with 16 direct and 6 indirect, and minimally elevated SGOT. The alkaline phosphatase was twice normal value a couple of weeks ago, and now is about 6 times the upper limit of normal. Clearly this is obstructive jaundice. Let me then say the workup of a patient suspected of having obstructive jaundice always begin with a sonogram, an ultrasound of the right upper quadrant. That sonogram will confirm that this is obstructive, and will do that by showing dilated intrahepatic, and depending on the level of obstruction, potentially dilated extrahepatic ducts as well. So dilated intrahepatic and perhaps dilated extrahepatic biliary ducts confirms in the sonogram that yes, this is obstructive jaundice. But the sonogram also begins to point out what is the likely reason for the obstructive jaundice. Because obstructive jaundice could be due to stones, benign disease, or could be due to a cancer, malignant disease. The cancer in turn could be 3 different ones, and the sonogram will not tell you which of the 3. But in the sonogram, in addition to looking at the ducts, the sonographer makes a good effort also to look at the gallbladder. If we see on that sonogram a gallbladder full of stones that is not dilated, it has a thickened wall and is full of stones, then there is a good chance that the genesis of the obstructive jaundice is in fact gallstones that have now migrated to the common duct. And don't be, by the way, put off by the fact that the sonographer might not identify the actual stone that is in the common duct, because those are often not seen. In fact, the accuracy of the sonogram for identifying the stone in the common duct itself is probably no better than 50%. And this is due to the fact, incidentally, that whereas the sonogram is excellent to show us the interface between solid and liquid, the echoes created by a stone in the vial are very well shown by the sonogram. The enemy of the sonogram is air. Air makes the sonogram have difficulty. And the duodenum, which is full of air, may be lying right in front of that area of the common duct where the stone might be. But as I was pointing out, the sonogram may give us a hint of the nature of the jaundice, because if instead of showing a contracted gallbladder full of stones, the sonogram shows a big, distended, thin-walled gallbladder, this is highly suggestive then that the obstructive jaundice is malignant, that the patient has either a cancer of the head of the pancreas, a cancer of the ampulla of water, or a cancer of the common duct. Now this is an observation that in fact was made at the turn of the century by clinicians in Europe, Courvoisier and Terrier. The clinical observation being at the time that if one palpated a big, dilated, but non-tender gallbladder in a patient that had obstructive jaundice, this patient was likely to have malignant disease. And the genesis of this is the fact that if you get a stone in the common duct as a reason for the obstruction, that stone came from the gallbladder. And that gallbladder has had stones and for years. And therefore the wall of the gallbladder is now thickened and leathery, chronically inflamed, and it cannot dilate. It cannot distend. On the other hand, the perfectly normal gallbladder of the individual who unfortunately develops a cancer that obstructs the biliary tract is able to dilate the same way the rest of the biliary tract dilates. So if the sonographic report is dilated intrahepatic ducts, dilated extrahepatic ducts, and a big, thin-walled, dilated gallbladder, That would be highly suggestive of being a cancer. All right, let's begin to go through the vignettes, and then we'll talk about what we do in each of the findings that we might have. Vignette number 52. A 40-year-old obese mother of 5 children presents with progressive jaundice, which she first noticed 4 weeks ago. She has a total bilirubin of 22, with 16 direct and 6 indirect, and minimally elevated SGOT. The alkaline phosphatase is about 6 times the upper limit of normal. She gives a history of multiple episodes of colic at right upper quadrant abdominal pain brought about by the ingestion of fatty food. We can tell from the kind of patient that presents in this question that this is likely to be an individual with gallstones. She is a classical lady in her 40s, obese, with many children. But what we're going to do next is something we already agreed on. She needs a sonogram. Now, I would expect that in this case, a sonogram would show the dilated intrahepatic ducts, the dilated extrahepatic ducts, and would show a gallbladder full of stones, but contracted, not dilated. And in that case, then, the sonogram is saying, yes, it is obstructive, and it's probably due to stones. And if we have that probability that it is due to stone, then the next move after that will be the ERCP, the endoscopic retrograde cholangiopancreatography, that gives us the high-quality picture that shows a stone or stones in the common duct, and enables also the endoscopist to do a sphincterotomy to retrieve the stones, to clean up the common duct. So all we have left to do on this lady then is a cholecystectomy, so she doesn't keep sending stones to the common duct. Let's move on to vignette 53. A 66-year-old man presents with progressive jaundice, which he first noticed 6 weeks ago. He has a total bilirubin of 22, with 16 direct and 6 indirect, and minimally elevated SGOT. The alkaline phosphatase is about 6 times the upper limit of normal. He has lost 10 pounds over the past 2 months, but is otherwise asymptomatic. The sonogram shows dilated intrahepatic ducts, dilated extrahepatic ducts, and a very distended, thin-walled gallbladder. Well, we already know then that this is 1, obstructive jaundice, and 2, malignant. This is obstructive jaundice due to a tumor, because it gives us that very distended, thin-walled gallbladder that is not full of stones. But now this could be one of 3 potential tumors. This could be a cancer of the head of a pancreas, growing in the head of a pancreas and eventually occluding the common duct by pushing from the outside. It could be a cancer growing from inside the common duct, a cholangiocarcinoma growing right into the lumen, or it could be a cancer of the ampulla of Vater, adenocarcinoma of the duodenal mucosa that happens to begin right at the ampulla of Vater and therefore occludes the biliary tract. The next move then in this circumstance is to do a CT scan, a non-invasive study, which if the patient has a cancer of the head of the pancreas is likely to show it. Because unless the cancer in the head of the pancreas by an incredible coincidence began to grow right next to the common duct, unless that's the situation, or a cancer of the head of the pancreas that began to develop someplace else on the head of the pancreas, to get to the point of occluding the common duct, it has to grow to a significant size. And in that significant size, it'll be enough then to be seen in the CT scan. And if that's the case, then we can do biopsies, percutaneous biopsies, and proceed from there. On the other hand, if that CT scan is negative, it suggests that it's either a very small cancer of the head of the pancreas that is not big enough to be seen, or it's one of the other 2. Because both the cholangiocarcinoma arising in the duct itself and the cancer of ampulla of Vater, they don't need to be enormous to produce obstructive jaundice. Given their very strategic location, they occlude the duct as soon as they are cm in diameter or thereabouts. And so in that case, then the next move is the ERCP. So the ERCP would be the thing to do after the CT scan, if the CT scan was not diagnostic. Vignette 54 illustrates what that ERCP might show in different circumstances. A 66-year-old man presents with progressive jaundice, which he first noticed 6 weeks ago. He has a total bilirubin of 22 with 16 direct, and minimally elevated SGOT. The alkaline phosphatase is about 6 times the upper limit of normal. He is otherwise asymptomatic. The sonogram shows dilated intrahepatic ducts, dilated extrahepatic ducts, and a very distended, thin-walled gallbladder. Except for the dilated ducts, CT scan is unremarkable. ERCP shows a narrow area in the distal common duct and the normal pancreatic duct. This is then suggestive of a cholangiocarcinoma. The tumor is arising from inside the distal common duct. It probably has a sort of a little apple core, appearance to that, and the pancreatic duct is normal because there's nothing pushing from the outside, as would be the case if it were a primary tumor from the head of the pancreas. We would then do brushings to obtain cytologic confirmation that this is a cholangiocarcinoma, and actually this is one of the most curable of the cancers that produce obstructive jaundice. This patient could get a Whipple operation, a pancreatic duodenectomy, and have a significant chance of survival, which is not the case for the primary tumor of the pancreatic tissue. Vignette number 55 gives us another example. A 64-year-old woman presents with progressive jaundice, which she first noticed 2 weeks ago. She has a total bilirubin of 12, with 8 direct and 4 indirect, and minimally elevated SGOT. The alkaline phosphatase is about 10 times the upper limit of normal. She's otherwise asymptomatic, but is found to be slightly anemic and to have positive occult blood in the stool. The sonogram shows dilated intrahepatic ducts, dilated extrahepatic ducts, and a very distended thin wall gallbladder. Let's analyze this one. We have evidence of obstructive jaundice, high alkaline phosphatase, dilated duct, and suggestion that it is malignant, a big distended thin wall gallbladder. But we also have a patient with anemia and blood in the GI lumen. And it's always a good idea to bet on one single diagnosis to explain all the findings, rather than 2 separate diagnoses. So it would not be a good idea here to think, well, the lady must have a cancer of the head of the pancreas producing obstructive jaundice and a cancer of the cecum producing anemia and blood in the lumen. We need to find one single explanation that gives us both the obstructive jaundice of a malignant nature plus the blood in the lumen. And indeed, one of the 3 cancers known to produce obstructive jaundice can do that, and that would be the ampullary cancer. The ampullary cancer is an adenocarcinoma that grows in the mucosa of the duodenum. It grows into the lumen of the duodenum. And like all adenocarcinomas that grow into the lumen of the GI tract, it may bleed. So we have the anemia, we have the occult blood in the stool because of the cancer there, and given its location in the ampulla mater, it is also producing the obstructive jaundice. With that kind of a background, we would then not continue the workup with a CT scan, because a CT scan is unlikely to show the tumor. These are small tumors, the cancer of ampulla mater. We would actually do the endoscopy here. In fact, we don't need the whole ERCP. The E of the ERCP will take care of it. In other words, this patient doesn't need the endoscopic retrograde cholangiopancreatography. As soon as the endoscopy is done, the endoscopies will see the tumor in the ampulla mater, biopsy that, confirm the diagnosis. This is another curable malignant obstructive jaundice. So actually, the best possibilities from the viewpoint of potential cure for a patient are to have a cholangiocarcinoma in the distal part of the duct, not at the bifurcation because that's very difficult to resect, but in the distal part of the duct, or to have the ampullary cancer. Both of these, with a Whipple operation, a pancreatic duodenectomy, there is a very significant chance of complete cure. Well, one more example. Vignette 56. A 56-year-old man presents with progressive jaundice, which he first noticed 6 weeks ago. He has a total bilirubin of 22, with 16 direct and 6 indirect, minimally elevated SGOT. The alkaline phosphatase is about 8 times the upper limit of normal. He has lost 20 pounds over the past 2 months and has a persistent, nagging, mild pain deep into his epigastrium and in the upper back. His sister died at age 44 from a cancer of the pancreas. A sonogram shows dilated intrahepatic ducts and dilated extrahepatic ducts and a very distended thin wall gallbladder, and we can make a pretty good guess what's wrong with this patient. We know it is obstructive jaundice, high alkaline phosphatase, dilated ducts. We know it is malignant, big distended gallbladder. We also know it's cancer of the head of the pancreas. We know it runs in families, sister died of that. And we know, as we pointed out before, that for a cancer of the pancreas to occlude the common duct, typically grows to a significant size so that it finally encounters the duct and pushes on it. And we have evidence of that here by the fact that the patient has this constant, nagging, deep epigastric and back pain. That's the cancer of the pancreas growing into the retroperitoneal tissues. And so the first thing we want here, we've already done the sonogram. The next thing we want here is a CT scan. The CT scan will show this tumor, will be a big one. And then we can do percutaneous biopsies, and then probably only palliative treatment, because this is a big one. This one will not be resected. All right, let's move on now to a chapter devoted to biliary tract disease. I think it may be a very good idea, before we go into the vignettes, to review a little bit of the background of biliary tract disease. For all practical purposes, biliary tract disease revolves around gallstones, certainly for purposes of the exam. Those are the kinds of questions we're likely to have. Now, gallstones could be present in the gallbladder and give no problem. So a patient could have gallstones and be completely asymptomatic, and we could stumble upon the gallstones because a sonogram or a CAT scan or an X-ray was done for some other reason. If that is the case, and indeed a careful history shows that there are no symptoms referable to the gallstones, we leave them alone. Asymptomatic gallstones have a very low rate of conversion to symptomatic. It's about 2% per year. So we can leave alone the patient that has asymptomatic gallstones. Now, the next thing that could happen with gallstones is the gallstone could get impacted at the cystic duct as the gallbladder contracts and tries to push it through. And that gives rise to a biliary colic. This is often triggered by the ingestion of fatty food. This is what makes the gallbladder contract. And then the individual develops colicky abdominal pain in the right upper quadrant, radiating to the back, to the shoulder, nausea, vomiting. But most of the time, these biliary colics are of short duration. Within 10 or 15 or 20 minutes, a little stone falls back into the gallbladder lumen, and the attack is over. The patient never develops an inflammatory process. That patient, when examined by a physician, will have no physical findings, only the history of having had an episode of colicky pain. But in this situation, this is no longer an asymptomatic patient. This is a patient now who has manifestations of biliary tract disease. And in that case, we need to do first the sonogram, which is the way we begin all the workups for biliary tract disease. Let me remind you, I pointed out to you that we begin the workup of what we think is obstructive jaundice always with a sonogram. We also begin the workup of anything we think is biliary tract disease always with a sonogram. The sonogram will confirm that gallstones are present, and then we will do an elective cholecystectomy, which nowadays is almost invariably done laparoscopically. But the patient who begins with a biliary colic as described could go on to develop acute cholecystitis. The stone may not fall back, even with pharmacological help. We often, if you see a patient who's having a biliary colic, often anticholinergic medication helps break the cycle and interrupt the attack. But if it doesn't, if the attack continues, the obstruction continues, after a number of hours, then an inflammatory process sets up. The patient then develops constant pain, develops signs of peritoneal irritation in the right upper quadrant, and develops fever and leukocytosis, and develops, in fact, acute cholecystitis. We begin the workup of acute cholecystitis also with a sonogram. And the sonogram could confirm the diagnosis by giving us three findings. There are stones on the gallbladder. The gallbladder wall is thickened, and there is pericholecystic fluid. Those three things confirm the diagnosis. It is acute cholecystitis. We treat acute cholecystitis typically medically at first. Nasogastric suction, IV fluids, intravenous antibiotics. Let it cool down, which it will do in about 85% of cases. And once it has cooled down, electively and a more convenient time, a cholecystectomy is done so the problem doesn't recur. I might point out that among the patients less likely to cool down, that 15% that didn't get better with a medical management, among those we find males, and particularly diabetic males. So we are often ready to jump in and operate pretty quickly the diabetic male who develops acute cholecystitis, because we know that person is less likely to cool down with a medical management. But for that matter, we would operate anyone who doesn't cool down. So if you have a question on the exam where a patient came in, the description is good for acute cholecystitis, the patient was placed on antibiotics, nasogastric suction, IV fluids, and we're told 6 hours later he's worse, well, then the answer is emergency cholecystectomy. But there is another inflammatory process that could happen in biliary tract disease that is in fact of far more ominous significance than acute cholecystitis. And that is acute ascending cholangitis. If what we have is a gallstone that rather than being impacted at the cystic duct moves on to the common duct, and rather than producing complete obstruction that would lead to obstructive jaundice, as we already reviewed, produces partial obstruction that allows ascending infection, then we have a deadly condition called acute ascending cholangitis. This is typically an older patient, a very sick patient. That patient also has evidence of an inflammatory process in the right upper quadrant. Right upper quadrant pain, constant, with a guarding and the rebound, and the pain radiated to the right shoulder and to the back, and nausea, vomiting. But this is a much sicker patient. The fever is not 101 or 102. It's like 104 or 105 with chills. The white count is way up. And classical. This individual will also have some degree of obstruction to the biliary flow. Now the stone and the inflammatory process in the common duct itself, not in the gallbladder. So the bilirubin will be elevated, 6, 7, 8, rather than a normal bilirubin, and even more characteristic, an enormous, gigantic, king-size elevation of the alkaline phosphatase. I might remind you that alkaline phosphatase is actually produced in the lining of the hepatic ducts. Anything that makes the lining of the hepatic ducts angry, they make more alkaline phosphatase. Obstruction is one of the things that do it. But even more than obstruction is the presence of pus in the common duct. So infection of the biliary ducts, as in acute ascending cholangitis, it will trigger very high levels of alkaline phosphatase. Acute ascending cholangitis is a real emergency. We have to treat the patient with intravenous antibiotics, hospitalization, etc. But we also have to immediately decompress that biliary tract. We do this most commonly by means of an ERCP, an emergency ERCP that eventually leaves a little catheter above where the stone is, draining that common duct. Could also be done with a percutaneous transhepatic cholangiogram, a PTC. It could be done surgically if needed, although the latter is rare. And finally, last potential entity that could encounter biliary tract disease is a stone that gets impacted at the ampulla vater, occluding both the common duct and the pancreatic duct, and leading therefore to acute pancreatitis. Let's go ahead and treat the vignettes. Vignette 57. A white, obese, 40-year-old mother of 5 children gives a history of repeated episodes of right upper quadrant abdominal pain, brought about by the ingestion of fatty foods and relieved by the administration of anticholinergic medications. The pain is colicky, radiates to the right shoulder and around to the back, and is accompanied by nausea and occasional vomiting. Physical exam is unremarkable. This lady doesn't have an inflammatory process, no fever, no leukocytosis, no tenderness, no gargling. But she's giving us a very clear picture of biliary colics. She's been having little stones impacted at the cystic duct that have then fallen back. But she's having biliary colics. So what does she need? She needs a sonogram, which will show that indeed she has gallstones, and then she needs an elective cholecystectomy. Vignette number 58. A 43-year-old obese mother of 6 children has severe right upper quadrant abdominal pain that began 6 hours ago. The pain was colicky at first, radiated to the right shoulder and around towards the back, and was accompanied by nausea and vomiting. For the past 2 hours, the pain has been constant. She has tenderness to deep palpation, muscle guarding, and rebound in the right upper quadrant. Her temperature is 101, and she has a white count of 12,000. But her liver function tests are normal. This is a very good description of acute cholecystitis. There is an inflammatory process, no question about it. Right upper quadrant, tenderness and rebound and muscle guarding and fever and leukocytosis. But the level of the fever, 101, the level of leukocytosis, 12,000, and more importantly, liver function tests which are normal, which means there is no stone in the common duct, there is no pus in the common duct. What do we start the workup with? Well, we know, with the sonogram. So we'll do the sonogram, and if we're lucky, we'll have the 3 findings. The sonogram should show stones in the gallbladder, a thickened gallbladder wall, and pericholecystic fluid. It would also show, incidentally, that there is no dilatation of the biliary ducts, excluding by the diagnosis of acute ascending cholangitis. Now, in a very rare case, we might have a patient who has this clinical presentation, has a sonogram done, but the sonogram is inconclusive. If the sonogram is inconclusive and we need to make this diagnosis, there is another test we can use, the IDA scan. We inject intravenously a compound It could be decida, papida, a number of things that end with ida. A compound that can be radioactively tagged, which the liver then will take from the blood and put into the bile. So wherever bile goes, radioactivity will go, and a scan of the patient will show where it goes. When we do this IDA scan, and the patient who has acute cholecystitis, remember, to get acute cholecystitis, you have that stone still impacted at the cystic duct that led to the inflammatory process in the gallbladder. The radioactively labeled compound will then be seen in the scans to be present in the liver, to be present in the common duct, to be in the duodenum, but not in the gallbladder. The gallbladder is out of the circuit because it's plugged up. If we, on the other hand, do an IDA scan on a patient that we think has acute cholecystitis, and we see the radioactive compound in the liver, in the common duct, in the duodenum, and in the gallbladder, that patient doesn't have acute cholecystitis. The management, as we pointed out before, then begins then with MPO and nasogastric suction and IV fluids, cool down, elective cholecystectomy at a later date. Now there is big vignette number 59. A 73-year-old obese mother of 6 children has severe right upper quadrant abdominal pain that began 3 days ago. The pain was colicky at first, but has been constant for the past 2.5 days. She has tenderness to deep palpation, muscle guarding, and rebound in the right upper quadrant. She has temperature spikes of 104 and 105 with chills. Her white count is 22,000 with a shift to the left. Her bilirubin is 5, and she has an alkaline phosphatase of 2,000, about 20 times. This is a classical description of acute ascending cholangitis. We can also tell right away that this is an inflammatory process in the right upper quadrant, affecting the biliary tree probably. But you can tell as you read this, it's an older patient, a sicker patient. The fever is not 101 or 102, but it's 104, 105. There's chills with a very high fever. The very high white count. The bilirubin now that is elevated, and even more classical, the signature of a problem, the very high alkaline phosphatase. The diagnosis then is acute ascending cholangitis. The lady needs intravenous antibiotics, hospitalization, very intensive care. But in addition to that, she needs emergency, immediate decompression of the biliary tract, preferably by ERCP. All right, let's have another one, vignette number 60. A white, obese, 40-year-old mother of 5 children gives a history of repeated episodes of right upper quadrant abdominal pain, brought about by the ingestion of fatty foods and relieved by the administration of anticholinergic medications. The pain is colicky, radiates to the right shoulder and around to the back, and is accompanied by nausea and occasional vomiting. This time she had a shaking chill with the colicky pain, and the pain lasted longer than usual. She has mild tenderness to palpation in the epigastrium and right upper quadrant. Laboratory determinations show a bilirubin of 3.5, an alkaline phosphatase 5 times normal, and serum amylase 3 times normal value. This is a good description for biliary pancreatitis. For biliary pancreatitis to occur, the gallstone has to be at the ampulla mater, which means there will be some degree of biliary obstruction as well as whatever is happening to the pancreatic duct. And that some degree of biliary obstruction is manifested here by the shaking chill that the lady had with the colicky pain. That was a transient episode of cholangitis, in fact. And it's manifested by the bilirubin that is elevated at 3.5 and by the alkaline phosphatase that is elevated. But in addition to that, we have the serum amylase, which is a signature of acute pancreatitis. Most of these patients pass the gallstone that is producing the pancreatitis. So the management here Well, we begin with a sonogram that will show the dilated ducts in this case, and the stones, and the gallbladder, and so on. But after we do that sonogram, the management here begins by sort of watchful waiting. IV fluids, antibiotics, general support of the patient, nothing by mouth, and we wait, and most of these people get better. The stone is passed. The pancreatitis gets better. The amylase level comes down. In the rare case where it doesn't, if you're given in an exam question this kind of presentation, but then you're told for 2 days the lady has been MPO, nasogastric suction, and she's getting worse. The level of amylase is higher, and the bilirubin level is higher, and it's clear that the stone hasn't left the ampulla. Then an emergency ERCP would be the thing to do. And in the ERCP, a sphincterotomy is done, and the stone is extracted, and then all you're left with is the need for the cholecystectomy at a later date. Well, let's go ahead now and move to a chapter related to the pancreas. Vignette number 61. A 33-year-old alcoholic man shows up in the ER with epigastric and mid-abdominal pain that began 12 hours ago, shortly after the ingestion of a large meal. The pain is constant, very severe, and radiates straight through to the back. He vomited twice early on, but since then has continued to have retching. He has tenderness and some muscle guarding in the upper abdomen, is afebrile, and has mild tachycardia. Serum amylase is 1200, and his hematocrit is 52. Let's analyze this case. We were already thinking pancreatitis could well be the topic when we read at the very outset that this is an alcoholic man who then has abdominal pain. In fact, the description of the location of the pain, the way it began, is good for pancreatitis. So clinically, this is a good description of pancreatitis. We make the diagnosis of pancreatitis by the determinations either in the blood or in the urine of either amylase or lipase. The choice between amylase and lipase to some extent is the preference of the physician. Amylase has been in use for probably much longer than lipase, and so there are many physicians who are in the habit of depending on amylase determinations for this diagnosis. There are those who feel that lipase is a little more specific to the pancreas as opposed to amylase. So it could be either amylase or lipase. You probably would not be given both on the same exam question. But the choice between serum and urinary determination depends on time. If you look at the way these laboratory values evolve, the elevation of the serum amylase or the serum lipase occurs shortly after the onset of the disease. Within 12 hours it's way up. But after about 2 days it's back down to normal. The urinary amylase or lipase, on the other hand, begin to go up around the second or third day, reach the top fourth, fifth day, and then go down. So if the vignette says we're seeing the patient 12 hours after the onset of the pain, we want serum, either amylase or lipase. But if the vignette says we're seeing the patient 3 days later or 4 days later, then we want urinary, either amylase or lipase. But we want something else, which was in this vignette. When we diagnose acute pancreatitis, we also need to establish, is it the usual, relatively benign, acute edematous pancreatitis? Or are we dealing with the fortunately less common but far more devastating acute hemorrhagic pancreatitis? And the first clue for that is in the hematocrit. And we read in this vignette that the patient had a hematocrit of 52. The normal hematocrit for people who live near the sea level would be about 45. So a hematocrit of 52 is indicative that plasma has been taken away from the blood, and the remaining blood now is hemoconcentrated. And that is, in fact, in turn, an indication that edema is what has occurred in and around the pancreas. So this patient has acute edematous pancreatitis, and the management is to put the pancreas at rest. MPO, NG suction, IV fluid, the patient will get better in a few days. Let's contrast that one with the next one, vignette number 62. A 56-year-old alcoholic man is admitted with a clinical picture of acute upper abdominal pain. The pain is constant, radiates straight through to the back, and is extremely severe. He has a serum amylase of 800, a hematocrit of 40. Let me stop right there. We already have the indication, an alcoholic, their upper abdominal pain, the radiation to the back, that this is going to be pancreatitis. We have the confirmation with the serum amylase elevated. And we have a hematocrit of 40. That indicates this is not edematous pancreatitis, this is hemorrhagic pancreatitis. Well, we also have a number of other findings. Let me keep reading on this vignette because we're going to come back and analyze what all this means. He has a white count of 18,000, a blood glucose of 150, a serum calcium 6.5. He's given IV fluids, kept MPO with NG suction. By the next morning, the hematocrit has dropped further to 30. The serum calcium has remained below 7 in spite of calcium administration. BUN is now up to 32. He's developed metabolic acidosis and a low arterial PO2. This man not only has hemorrhagic pancreatitis, he's got a bad case of hemorrhagic pancreatitis. There was a gentleman by the name of Ranson. He happens to be dead now. But when Ranson was alive, he made a compilation of all the findings that had prognostic, predictive value in patients with pancreatitis. We know them now as Ranson's criteria. Ranson's criteria, in fact, provide a numerical way to assess prognosis. But I don't think you're going to be asked to put together the numbers and say this particular patient has a 52% chance of dying or whatever. In fact, this one on this vignette has a 100% chance of dying. But let me just identify with you which are those findings that indicate pancreatitis is bad. Which are the Ranson's criteria? Well, at the time of the admission, the low hematocrit, the elevated white count, the elevated blood glucose, and the low calcium. Those four indicate bad prognosis. By the next morning, the fact that the hematocrit has kept on dropping and the calcium hasn't gone up, very, very valuable signs of bad disease. And then after that, the remaining Ranson's criteria are the BUN going up, the metabolic acidosis, and the low PO2. And as I pointed out before, the mortality for this man, as predicted by those criteria, would be 100%. Now, what do we do in terms of treatment? Well, we again put the pancreas at rest, like we would have done for the patient with edematous pancreatitis. But the patient that has the hemorrhagic pancreatitis needs more intensive support. This is a patient who's going to go to the intensive care unit because we expect all kinds of complications are going to develop. One of the complications that's going to develop, often the common final pathway leading to death, is the development of pancreatic abscesses that destroy necrotic hemorrhagic gland. And our only hope of saving that patient is if those abscesses are recognized as soon as they develop and drain immediately. And so part of the management of a patient with acute hemorrhagic pancreatitis is daily CT scans. So that at the earliest indication of a collection of, pus, we can drain it. Well, let's move on. Vignette 63, a 57-year-old alcoholic man is being treated for acute hemorrhagic pancreatitis. He was in the intensive care unit for 1 week, required chest tubes for pleural effusion, was on a respirator for several days, but eventually improved enough to be transferred to the floor. 2 weeks after the onset of the disease, he begins to spike fever and to demonstrate leukocytosis. this is indeed a pancreatic abscess, one of the potential sequelae of hemorrhagic pancreatitis. Nowadays, as I pointed out, we like to diagnose these before they're obvious by doing the daily CT scan, but sometimes they don't show up at the time. May show up like this one 10 days later. If we have a febrile course on a patient who had acute pancreatitis within the last few days, that's indicative of pancreatic abscess. So now we need a CT scan to confirm it and percutaneous drainage. A pancreatic disease can lead to other sequelae. Let's read vignette number 64. A 49-year-old alcoholic man presents with ill-defined upper abdominal discomfort and early satiety. On physical exam, he has a large epigastric mass that is deep within the abdomen and actually hard to define. He was discharged from the hospital 5 weeks ago after successful treatment for acute pancreatitis. Let me read the next vignette, because this condition we're now going to review can happen in two different ways. Vignette 65. A 55-year-old woman presents with vague upper abdominal discomfort, early satiety, and a large but ill-defined epigastric mass. 5 weeks ago, she was involved in an automobile accident where she hit the upper abdomen against the steering wheel. Both of these are examples of a pancreatic pseudocyst, secondary to the disruption of a pancreatic duct, either from bad acute pancreatitis or from trauma. We can then have pancreatic juice leaking out of the pancreatic ducts where it should be and collecting nearby somewhere. A classical place where it collects nearby somewhere is in the lesser sac. And typically about 5 weeks go by from the original event, the trauma to the upper abdomen or the pancreatitis, for a collection of sufficient size to be now in the lesser sac to produce the pressure symptoms that are described here, early satiety, the vague discomfort, and to be palpable. So both of these are pancreatic pseudocysts. We can confirm the diagnosis with either a sonogram or a CT scan, either of which will show the picture of a collection of fluid in the lesser sac. It could be somewhere else near the pancreas. I'm using the lesser sac as the most common example. Now, what do we need to do about it? Our management of a pancreatic pseudocyst is dictated by our understanding of the natural history of that disease. There are 4 things that can happen to pancreatic pseudocyst. One is it could go away by itself. Happy outcome. But the other 3 things that could happen are very bad. That pancreatic pseudocyst could rupture into the peritoneal cavity and give massive fulminating chemical peritonitis. Or it could erode into major blood vessels nearby so the patient bleeds from the big vessel, either the aorta or the superior mesenteric or something like that, into the pseudocyst and exsanguinates. Or the pancreatic juice could become infected, secondary bacterial infection, and what was a pseudocyst becomes a pancreatic abscess, and then the mode of death would be septic. Fortunately, there is a timetable to these events, obviously with a million exceptions in real life, but good enough to guide us on the exam question. Most of the pancreatic pseudocysts that go away by themselves do so within the first 6 weeks that they have been there. Most of the deadly complications from a pancreatic pseudocyst, the rupture, the bleeding, the conversion to an infected mass, typically happen after 6 weeks. And so the standard approach in management for pancreatic pseudocyst is for the first few weeks we simply have careful observation. We keep repeating the sonograms or the CT scans to see if it's shrinking, if it's growing, if it's going away, in the comfortable knowledge that as long as we do that for the first few weeks, the likelihood of a disaster is unlikely.